Now, next speaker is Dr. Shamik
MOKADAM.
MOKADAM. He's going to talk to us about endophthalmitis management, early intervention with complete vitrectomy. Over to Shamik. Time.
Thank you very much.
Mike.
Mic परती नहीं चालू
दोनों चल ठीक. I would like to thank the AIOC for giving me this opportunity, and also my very own viewers for giving me this opportunity to be here. I would straight away go to the topic of today's discussion: endophthalmitis management. Uh, we all know about endophthalmitis. It is a medical emergency caused by infection of tissues or fluids inside the eyeball. It is a severe purulent intraocular inflammation. Early detection and early initiation of treatment is the key to the management. And the types we all know, it is exogenous, either post-trauma or post-surgical, or it could be endogenous. Principles of theory are either like so: killing the organism, removing the inflammatory debris, treating complications and preventing future complications of the infection, and intervene as soon as possible. So we all go on to the landmark study, that was the endophthalmitis vitrectomy study, which was done in 1990 to 94. And it was done to determine whether it is necessary in acute post-operative endophthalmitis to use systemic antibiotics or perform routine immediate vitrectomy. So what the results showed us was statistical visual improvement in PPV for visual acuity in PL or worse, and no significant improvement regardless of approach in group of patients with vision, hand movement or better. And they also showed that systemic antibiotics didn't show significant variation in visual improvement. However, there were limitations to this, and they were the use of non-contemporary vitrectomy equipment and conservative nature of the vitrectomy, which was mainly doing a core vitrectomy and avoiding the peripheral vitreous to be cut at all. So then we come to why vitrectomy in endophthalmitis. It reduces the inflammatory load and the bacterial load. It gives us more specimen for microbiology, gives direct visualization of the retina, better availability of antibiotics, and improves oxygenation of the retina. Then why early vitrectomy? So it is immediate treatment, prophylaxis at preventing possible complications, risk of surgery reduced because we have a better media, because the prolongation of the disease gives us corneal edema, corneal haze, and it makes it difficult to go inside the eye and try to do a complete vitrectomy. And it also prevents tissue fragility. Then why a complete vitrectomy? A complete removal of, it helps in complete removal of inflammatory material, that is the pus, and it gives better penetration of the antibiotics, in addition to the oxygenation of the retina and other things that I just enumerated earlier. So there have been studies which have shown complete and early vitrectomy for endophthalmitis. The CEVE study, studies which have shown early PPV has very good results visually, and a few others have also shown no additional benefits than intravitreal antibiotics alone. But then this CEV was proposed by Kuhn and Ginny, and they showed very good results in their small cohort. And other authors have also shown good results with this. In addition, they also have something called as CEV plus, where they do additional lavage of the vitreous in case there is a recurrence of inflammatory debris inside the eye. So what were the protocols that they followed? It was if they see endophthalmitis, immediately they'll look at whether there is a good reflex. Then if there is a good reflex, proceed with medical therapy and observe patient closely for about 24 hours. If there is improvement, continue with medical therapy. If no improvement, then we go ahead with vitrectomy. However, if there is no good reflex, straight away go for vitrectomy. And these studies have shown that CEV gives us good final visual acuity of almost 20, 40 or greater with early vitrectomies and complete vitrectomy. There is this big question of whether to remove the IOL or not to remove the IOL. Earlier, we used to remove IOL in practically every endophthalmitis that we used to see, but then there have been reports and studies where they have shown that removing an IOL is to be best avoided, especially in acute endophthalmitis, and in chronic we need to remove it because the inflammatory and infective material is right there in the capsular bag, and it is stuck onto the posterior surface of the IOL. So it is better to do an early explantation of the IOL and intervention along with intravitreal antibiotics. Our very own endophthalmitis management study group, which is based from India with Dr. T.P. Das and his group heading the study, and they have decided to go ahead with this prospective randomized multi-center study of post cataract surgery acute endophthalmitis with IOL implantation. And the primary intervention, what they are planning to do is intravitreal injection alone or vitrectomy based on something called as an inflammatory score. And the other thing is primary intravitreal antibiotics, which is randomized to either vancomycin plus ceftazidime or vancomycin plus imipenem. They have come out, this study was started in 2021, and they have these interim analysis of the EMS, which is already out. And they did mention that we need to consider the inflammatory score along with the presenting vision when we are to go ahead with the treatment and consider the treatment at all. And based on the availability, we also need to go ahead with susceptibility testing of all gram-negative bacterial growth whenever we have it. And if not, if we don't have the availability of such susceptibility testing, we should do a combination of vancomycin and colistin. So these were the interim results that are just out, but we still need to understand what would be their final outcome of the EMS, and we'll be getting it sooner. But then to conclude, we have CEV is a safe and effective initial treatment, and systemic antibiotics and retreatment, that is CEV plus of recurrent media opacification, this is recovery by almost 50%. IOL explantation in late chronic endophthalmitis, definitely to be done whenever we come across one case of late endophthalmitis. And as I just mentioned, EMS group outcomes would give us better insight to the use of newer microbiological tests and antibiotics used. Thank you. Sir, it is something, as I just mentioned, we need to just go ahead as soon as we know that we are looking at a case of it's an endophthalmitis, as soon as possible. That is what we have started seeing. And vitrectomy also, earlier we used to say we should do just the core vitrectomy, inject some intravitreal antibiotics. But nowadays we are moving more and more towards a complete vitrectomy, and the protocols that they have set up with the complete and early vitrectomy group is right from the corneal and the AC management to the vitreous management. And whenever we see that the retina is a little more fragile, or there is ischemic part of the retina on vitrectomy, we tend to go around that area and avoid direct vitrectomy over it. So there are protocols which have been set up by the CVE group, and we have got really good results. And they also mentioned that including silicone oil gives a good prevention of further growth of bacterial organisms around it.
I think a CV means induction of posterior vitreous detachment as well. So it has to be a guarded posterior vitreous detachment to be induced. And whenever we suspect a case of as a endophthalmitis, once we are sure that it's no longer just an inflammatory component that is TAS. Previously, we used to do just an aqueous tap and still inject intravitreals and then wait for, unless the disease forced us, we would not go for a vitreous surgery. But now the concept is, if I know that it is not a TAS in next 6-8 hours, instead of doing a intravitreal antibiotic, I will go directly with vitrectomy, because the advantage is I get an adequate sample for culture sensitivity as well as you have removed whatever the load of the organism is. And at that point of time, retina is not edematous and necrotic, so you can induce a PVD and near total vitrectomy is possible. So that is the advantage of this particular thing. So you should be doing a vitrectomy as a primary procedure of choice wherever facility is available. Yeah.
Vancomycin, yes.
Yeah, any drug which we are
Each drug
using,
which
of
is-
course, of course.
Yeah,
It has to
even-
be used in a proper dose.
I think it is the protocol is very clear. As soon as a peripheral center has started, is diagnosed it, intravitreal should give if you can give and go for early vitrectomy. Earlier you do it, better you have results.
Yes, sir. Yes.
And that's very well made. Thank you so much, Shamik. No, late onset is different. I'm talking about acute.
Even for late, we should go ahead with early vitrectomy and IOL removal.
See,
Because we know that the organisms are within the bag, and we need to remove the IOL, which is the cause. And many a times, even fungal endophthalmitis, which is again a delayed or chronic kind of endophthalmitis, it is best to remove the bag because we really don't
then
know
we have
where
to
this
remove, explant the
fungus
IOL.
is.
No, I think I would put it in a right way. If it is a chronic presentation that is happening after few weeks of quiescence, post-operatively, and you now have a flare of inflammation, first again decide whether it is inflammatory versus an infective. Once you are sure it's an infective, again you go for a primary vitrectomy instead of just doing a vitreous biopsy and trying to treat it with intravitreal antibiotics. So vitrectomy is the way to go. Now, should we do an IOL explantation along with it is a matter of debate. I would always like to preserve the IOL till the organisms forces me. So it would be always for me a second surgery. Means if there is a inflammation which is not getting under control, then as a secondary procedure. So first procedure try to salvage, because why did the whole primary surgery and patient undergo? So, and not necessarily that every time it can be an acne which is inside the bag. So that is the thing. So you should give benefit of doubt. Primary surgery try avoid unless.
I had 2-3 cases recently only, last 6 months back, for developmental cataract, especially in younger age group. I did cataract surgery, and after just 3 weeks they were fine, and after 3 to 4 weeks they started developing hypopyon. Now in that case we did a ESR, and the ESR were very highly raised. So my colleague, retina colleague, said me that okay, we'll go ahead with 1 hourly steroid and Toba and Vigomox we added, and with that only in 2 days we got a little bit improvement. Then we just continued with the steroid and antibiotic combination, and it got like
Two things I would like
not
to.
developmental cataract, like
Yeah.
developmental
Two
cataract.
things